All right. Well, thank you all for joining me today. I'm happy to welcome you to today's presentation on more than picky eating, spotting signs of ARFID. My name is Shivani, and I'm one of the managers of mission initiatives here at the National Eating Disorders Association. Again, I appreciate you all being here today. And before we get started, I'd like to share information about the work that we do here at NEDA and also our partner organization, EQUIP. So, NEDA is a nonprofit organization working to fundamentally change the way eating disorders are understood and treated, and to empower those affected to achieve lasting well being and recovery. Through campaigns like Eating Disorders Awareness Week and National Eating Disorders Screening Week, and through our Campus Warriors program, we are working to increase public understanding of these complex disorders. We provide information and resources through the Grace Holland Cozine Resource Center, our Understanding Eating Disorders presentation, and webinars like this. We also promote early intervention through our online screening tool, which is a resource we'll be highlighting later today. We also invest in groundbreaking research that helps to develop effective treatments. If you would like to support our work and more programming like this webinar, we'd appreciate any donations, and I will share a link in the chat later on. This webinar is presented to you in partnership with EQUIP. EQUIP is a pioneering virtual eating disorder treatment program that empowers patients to access evidence-based care from their own homes. Built by clinical experts and people with lived experience, their treatment is designed to help people achieve sustainable recovery. Each equipped patient has access to a dedicated multidisciplinary care team and receives an adaptable, personalized treatment plan. They treat patients of all ages, all eating disorder diagnosis, and in all 50 states, and they accept most insurance plans. I am happy to introduce you to our presenter today, Dr. Tana Luo, EQUIP's Senior Director of Program Development. Tana is a clinical psychologist with a PhD from the University of Southern California. She completed her predoctoral and postdoctoral training at the UC San Diego Eating Disorder Center. She specializes in treating pediatric eating disorders and has in-depth experience working with children, adolescents, and adults at different levels of care. If you have any questions during the presentation, please feel free to share them in the chat feature. And when we are towards the Q&A portion of the presentation, I will relay them to Tana. Now I will pass it on over to you, Tana. Please feel free to take it away. And thank you so much for being here and sharing your knowledge with our community.
Thank you so much, Shivani. Okay, I'm going to go ahead and share my screen. Okay, here we go. And I was just sharing with Shivani that I'm like on the cusp right now of losing my voice, but I think we'll be okay for the next hour or so. But if you see me like using a cough drop, that's what that's about. So really excited to be here today talking a little bit about ARFID and the role of early screening in detecting ARFID symptoms. Okay, so a couple of different learning objectives for today. So first, we're going to talk a little bit about what the key signs of ARFID are, and importantly, how ARFID is different than normative picky eating. We're going to talk a little bit about the importance of screening for ARFID, as well as some of the screening measures that are available. And then finally, I'll talk a little bit about how ARFID can be treated in a virtual setting. Okay, so first, what is ARFID? And those of you who are here might have varying levels of familiarity with ARFID, but I'll kind of go over a high-level overview of what some of the key features are of this disorder. So ARFID stands for avoidant restrictive food intake disorder, and it is an eating disorder that's characterized by problems with volume and or variety of food intake. So that means that the individual is having challenges with getting enough to eat, and or they're having challenges with getting enough variety in their diet. And importantly, these challenges with eating are not primarily driven by a desire to lose weight, a fear of gaining weight, or a desire to change one's body. Now, that's not to say individuals with ARFID can't experience body image concerns. It's actually not uncommon for individuals with ARFID to experience body dissatisfaction. But the key with ARFID is that the body image challenges or weight dissatisfaction issues are not the primary driver of the eating challenges. So that is, there are problems with eating that are really driven by something else. And we'll talk a little bit about what some of those mechanisms might be. Also, in order to meet diagnostic criteria for ARFID, the ARFID symptoms have to be creating notable problems in the individual's life. And so we usually think about problems in one of these four ways. So the first is that the eating challenges are getting in the way of weight. So either there is weight loss, or for children, there is lack of adequate weight gain or a failure to grow, as would be expected. So for this first criterion here, it can really show up in a lot of different ways. So if we're thinking about an adult patient with ARFID, that person might have experienced some acute weight loss. So all of a sudden they're losing weight related to their ARFID. Or again, for children or even adolescents, perhaps it's not necessarily this acute weight loss, but there's challenges with keeping up with their growth curve. The second way that ARFID can create problems is via nutritional deficiency. So, for individuals who struggle with getting enough variety in their diet, they could be at risk for certain nutritional deficiencies. The third way that ARFID can get in the way is that there's a dependence on supplements. So maybe the person is able to get enough nutrition, they're able to maintain adequate nutrients in their overall diet, but it's because they're reliant on things like Boost or Ensure, or perhaps they're reliant on tube feeding. But if we were to take away those supplements, then they're not getting enough to eat or a wide enough variety of foods to eat. And then the fourth way that ARFID can create problems is just in daily life and functioning. So if an individual is finding that their ARFID is getting in the way of their ability to go to school or socialize, or it's creating a lot of problems with their family, those are all ways that someone could still meet diagnostic criteria for ARFID. So when we think a little bit about how ARFID can show up, there's quite a bit of variability in the presentation of ARFID. We generally think of three primary presentations of ARFID. The common thread across all of these three presentations is that there's some degree of anxiety or distress that's related to eating. But I'm going to kind of go around these different presentations and talk a little bit about what they can look like. So the first presentation at the top here is food fears. So these are individuals who have a significant fear that something bad will happen if they eat. So they might be really scared that if they eat, they're going to vomit or become really ill, or if they eat, they might choke and die as a result of eating something. And it's not uncommon for individuals with this food fear presentation to have experienced some sort of a triggering event that then prompted the onset of their ARFID. So maybe an individual had a bout of food poisoning and then became really fearful after that bout of food poisoning that they would develop further illness or vomit because of food. So individuals with food fears tend to struggle with both volume and variety of food intake. So it's not uncommon for these people to not be eating enough and then also not be eating a wide enough variety in their diet. If we go down to this sort of yellow orange circle, we've got our selective eating presentation. So these are individuals who might commonly be seen as like picky eaters, but this is to a degree that it's actually getting in the way of their life. And we'll talk a little bit more on the next slide about the difference between picky and selective eating. But these are individuals who are essentially very sensitive to the tastes, textures, or other sensory properties of foods. So they might have an aversion to certain tastes and textures and have a very narrow variety of foods in their diet. These are also individuals who might be really anxious about trying new foods. So they've got their select group of safe foods. They know that these are familiar, kind of preferred foods, and it's really hard to branch out of those safe foods and try new foods. And then finally, we've got our lack of interest presentation. So these are individuals who just don't really enjoy eating. They might not experience hunger in the same way that another person might. And they might experience fullness a lot more easily than another person. So these are individuals who might go very long periods of time without eating because they don't have an appetite, they're not experiencing those hunger cues. And then when they do eat, they get full easily, and it's hard to kind of push past that discomfort that's associated with fullness. So these are individuals who might experience a lot of GI complaints. So when they do eat, they're worried about the feelings of fullness. They're worried about feelings of bloating or nausea or anything else that might accompany the eating. Individuals with a lack of interest in food tend to struggle primarily with volume of intake and regularity of eating. So again, going very long periods of time without eating, and then when they actually do eat, only eating a very small volume of food before becoming full. Now I've got these presentations up here as these sort of like three distinct presentations, but it's important to note that an individual can have any one, two, or three of these presentations. So we really like to think of these as more dimensional than categorical, where again, an individual could have any combination of these presentations. Okay, I do want to spend a little bit of time talking specifically about picky eating versus selective eating that we see in ARFID, because oftentimes there can be a lot of confusion about what the difference is, and sometimes selective eating in ARFID is chalked up to just normative picky eating. So I want to start actually in the middle of this Venn diagram. So similarities across picky eating and selective eating. In both of these cases, the individual might have a preference for certain types of foods, for certain brands of a food, or preparations of food. And in both of these situations, the individual might be hesitant or wary of trying new foods. But if we think about picky eating, this is something that can be very developmentally normal. If we think about toddlers, young children, even middle childhood, it's not uncommon for there to be some degree of picky eating. But within picky eating, we might see that there's still a willingness to try some new foods rather than an outright refusal to try any new food. With picky eating, the eating isn't causing too many problems in functioning or in health. Typically, when we see picky eating, there's still an ability to eat something from all five food groups. So there's overall still adequate variety in the diet. And picky eating tends to be transient. It tends to be temporary, which means that a kid, an adult might go through a period of picky eating, but then kind of grow out of it. Now, if we go over to the selective eating side, selective eating is a little bit different, even though on the face it can look just like picky eating. So within selective eating, there might be outright refusal to try any new foods because that fear of trying new foods is so strong. Selective eaters may be missing whole food groups. So if we think about kind of our primary main food groups, selective eaters might actually be unable to eat foods from like an entire food group or maybe even a couple of food groups. Importantly, the challenges with eating are causing significant distress and they're getting in the way in some meaningful way in functioning. So, again, they're getting in the way of work or school or just getting in the way of overall quality of life. The selective eating may also be impacting growth or overall health. The individual might be dependent on supplements because of the degree of their selective eating. And these tend to be difficulties that are long lasting. So, whereas with picky eating, it tends to be transient, kind of developmentally normal, people kind of grow out of it. With selective eating, we don't see that kind of temporary nature of the challenges that they kind of persist. And in many cases, they actually get worse over time. Okay, so let's talk a little bit about why screening for ARFID is so important. So we tend to see an earlier age of onset of ARFID, especially compared to other eating disorders. So we know that even young children are struggling with ARFID, so it's important for us to be screening early if we are noticing any challenges. As illustrated on the previous slide, symptoms of ARFID could be easily missed, right? So if there's confusion about what is picky eating versus selective eating, in some cases, symptoms might be minimized and missed early on. But we also know that ARFID can have serious medical consequences, as serious as medical consequences associated with other eating disorders like anorexia nervosa or bulimia nervosa. So it's important that we're detecting ARFID early on so that the individual can get treatment sooner rather than later. And we also know that, again, unlike sort of transient picky eating, ARFID symptoms are unlikely to improve on their own. So it's important that we're detecting the ARFID early on so that then we can provide that treatment to help the person recover. So I can talk a little bit about the screeners that are available, including a couple of free screening tools. But on this screen, I've got the 9-item ARFID screen, or the NIAS for short. And this is a quick ARFID screen for individuals ages 8 and up. As the title suggests, it's 9 items and it covers all 3 presentations. So there are different questions that kind of are aimed at assessing for each of the different presentations. This is, excuse me, available for children, adolescents, adults, as well as parents. And it's available in a couple of different languages, which is really nice. Now, on the other side here, we've got the PARDI ARQ. It stands for the PICA ARFID Rumination Diagnostic Interview. So there's a version of this that's an actual clinical interview that would be administered by a clinician, but there's also this questionnaire version. It's a little bit lengthier. It's 32 items, but it also covers all 3 ARFID presentations. It's available for adolescents, adults, and parents, and is also available in a couple of different languages, which is great. The nice thing with the PARDI ARQ is that it also provides a measure of how severe the symptoms are. So not only is there this presentation present, but how severe are the symptoms. And also wanted to talk about 2 free screening tools that are available. So NITA has a really amazing screening tool available on their website. This is an online screening tool. It's free, it's confidential, and it's appropriate for individuals ages 13 and older. What's really great about this screening tool is it provides screening for all different types of eating challenges, including ARFID, and it's available in both English and Spanish. Equip also has an ARFID specific screener, so similarly available online, and provides items to respond to that also kind of assess for the different presentations of ARFID. In both of these cases with these screening tools, depending on the responses and results of the screener, there are kind of next step resources that you can utilize in the event that the screener indicates there might be an issue related to ARFID. Okay, so now I can talk a little bit about Equip's ARFID treatment specifically. So as Shivani mentioned, Equip relies on treatments that utilize support structures, and these treatments are delivered virtually for lasting recovery at home. When we think about ARFID treatment specifically, the main treatments that we utilize are family-based treatment for ARFID, or FBT ARFID, and cognitive behavioral therapy for ARFID, or CBTAR. And our treatment has really been designed to be delivered virtually so that individuals can involve their family, friends, spouses, really anyone that they need to ensure that they are creating a recovery supporting environment at home and that they're able to achieve lasting recovery. So a little bit about these 2 primary treatment approaches that we use for ARFID at Equip. So the first is FBT for ARFID. This is really great for younger kids. For those of you who are familiar with FBT, it's a very similar model, but with some adjustments specific to ARFID. Within FBT for ARFID, parents are really in the driver's seat. So the goal is to really empower parents to um, renourish their child if that's needed, as well as to tackle any of the specific ARFID symptoms that their child might be struggling with. Similar to FBT for other eating disorders, FBT for ARFID proceeds in a couple of different phases. So there's phase 1, phase 2, and phase 3 of FBT. Now, CBT for ARFID, again, that's cognitive behavioral therapy for ARFID, has been tested in children, adolescents, and adults. And there are 2 different versions of CBT for ARFID. So there's an individual version of CBT for ARFID, which can be a really great fit for some adults. And then there's also a family supported version of CBT for ARFID, which is really great for children, adolescents, as well as adults, because we're really proponents of including families and supports in treatment, regardless of the age. But CBT for ARFID is all about kind of tackling the specific mechanisms that might be maintaining a person's symptoms. So really identifying what is driving, for example, their food fear, and then really tackling those fears and helping the patient to overcome the food fears. Similarly to FBT for ARFID, CBTAR also proceeds in 4 different phases or in different phases. There are some similarities across these treatments. So the first is that if an individual has lost a significant amount of weight or they're not growing as would be expected, we would be focusing on weight gain regardless of what the treatment modality is. So weight gain and regular eating are the focus of treatment in both cases if that's needed. In both cases, we really encourage the involvement of supports. For younger kids, we might require that supports be involved just because we're working with a younger kid and logistically we need parents to be involved. But regardless, again, of the age, it's really helpful to have supports in the process. And again, both proceed in different phases. So a little bit about our care team model here. So at Equip, we provide each individual with a 5-person multidisciplinary treatment team, which includes a therapist, a medical provider, a dietitian, a peer mentor, and a family mentor. So the therapist is really the one who's responsible for providing the treatment intervention. So whether that's FBT for ARFID or CBTAR, the therapist is really on point to be providing that treatment. The medical provider is a really key player here because the medical provider is monitoring to ensure that the individual is medically stable and is really working to resolve any acute medical complications that are directly related to the ARFID. The dietitian on the team is responsible for determining, so if someone needs to gain weight, they're kind of responsible for determining what that target weight range is that we're shooting for. And then they play, of course, a key role in developing and recommending a meal plan, as well as doing menu planning for patients and families. And then we've got our peer mentor and family mentor. So, a peer mentor is someone who themselves has recovered from an eating disorder and is now in a position to support other people going through the process. And similarly, a family mentor is someone who has supported a loved one through the process of eating disorder recovery, and they are now in a position to support other caregivers or supports in this process. Our peer and family mentors are a really valuable source of not only validation, but concrete skills coaching because they've really been there and they have that experience. A little bit more about our model. We offer flexible sessions. So we really try to meet each patient and family where they are and kind of schedule according to a schedule that works for them. We also have the ability to increase, the frequency of sessions if needed or decrease the frequency of sessions as needed. We also offer online messaging in between sessions. So if anyone ever needs support in between sessions, they are able to reach out to their care team via the online portal. And then finally, we offer a variety of ARFID groups and workshops. So these are specific spaces where individuals and their families can gather with other people struggling with ARFID to get support, to learn a little bit more about strategies that are working for other people, and to just have that sense of community building. And then we also offer ARFID specific workshops. So these are more kind of educational, they're kind of webinar style where individuals can join and learn different tools or skills that are specific to ARFID treatment. Okay, and a little bit more about what treatment can look like at Equip. So again, the first step is usually weight gain and or regular eating, if that's needed. And we tend to focus primarily on increasing overall volume of intake. So even if someone is really struggling with their variety, we really want to focus on volume first so that we ensure that the person is eating enough before we work on variety. And then once we've gotten into a nice rhythm of weight gain or improving that regularity of eating, then we kind of take a pause and we think about, okay, what is going to be the next step? So what's the plan and what's getting in the way of the most of this person's life? So for those people who are presenting with, let's say, fear of aversive consequences, and they're also struggling with selective eating, we would really want to think with them, okay, what's getting in the way the most right now? And let's tackle that set of symptoms first before we then move on to tackling another set of symptoms of ARFID. Then we move into the phase of actually addressing the specific symptoms. So, reducing the fear of food or expanding the dietary variety or working on tolerance of physical sensations associated with eating. So, whatever it is that's the most important to the patient. And then after we've gotten to a place where the patient is feeling really comfortable about their progress, they've met their treatment goals, then we kind of launch into the last phase, which is relapse prevention planning. So how can we put a plan in place and supports in place to ensure that all of the gains that were made over the course of treatment can be maintained long term? Okay. So, to summarize what we talked about today, there are three general presentations of ARFID. There's food fears, selective eating, and then low interest, and a person can have one, two, or all three presentations. Early screening is really essential for catching when ARFID may be at play and for ensuring that then the individual is able to get the support that they need. And then finally, our virtual treatment model here at Equip is based on clinically supported treatments delivered at home that really leverage supports in the individual's life. Okay, if you are interested in learning a little bit more, here is our website and specifically our partnership with NITA, a phone call that you can call. And then if you are wanting to get some more information about what treatment could look like at Equip, we also offer a public pre-admission support group, again, kind of open to the public for people to join and ask any questions that they might have about the treatment process. Okay. So that takes us to the end, which leaves us a nice chunk of time then for a Q&A.
Well, thank you so much, Tana, for the really important information. And we really wanted to center a lot of this webinar on some Q&A because we do get a lot of questions about ARFID, and they did heavily stream in throughout your presentation. So the first question is, can you meet some criteria for ARFID, but not all, and still be considered for treatment?
Yes, absolutely. So, if there are any questions about like, oh, I've noticed that my loved one or myself that I'm struggling with like quality of life, but I haven't necessarily lost weight or I'm not dependent on supplements. Even experiencing problems in one of those four areas is enough to meet criteria for ARVID. So I would say that if either you or a loved one is exhibiting any challenges with eating that kind of feel like ARFID, we would definitely be able to provide support or at least have a conversation about what treatment could look like.
Okay, thank you so much. Um, so there are some people asking about trauma when it comes to ARFID. So someone is saying that their child was diagnosed and it was determined that he developed ARFID due to family trauma, and not specifically related to his like food intake and other experiences. Have you heard of this? And can you talk a little bit more about the association of psychological trauma and ARFID?
Sure. So I can talk about trauma in two different ways. Um, so the first way is a little bit more straightforward, perhaps. So when we think about that food fears presentation of ARFID, so someone is really afraid of vomiting or choking, it's not uncommon for there to have been some sort of a traumatic event related to eating that would then kind of spurn the onset of ARFID. But usually when we're thinking about trauma in that way, it's a very specific, again, like food related event. So there was a vomiting episode, or maybe there was a choking incident, and then the individual developed ARFID as a result. So that's one way that we can think about trauma. The other way that we can think about trauma is potentially as serving as a vulnerability or a risk factor to developing ARFID in someone who is already predisposed to develop ARFID. So in this case, it sounds like there was potentially some interpersonal or family related trauma that seemed to like predate then the onset of the ARFID. Um, while I'm not familiar with the research on like that type of trauma and prevalence of ARFID, I think it's certainly something that can happen. Again, if an individual is already predisposed to struggling with eating, and we know that there is a genetic component to eating disorders as well as to ARFID, there are certain like neurobiological vulnerabilities to eating disorders, including ARFID. So if we think about someone who's already kind of primed to develop this disorder, then any sort of external stressor could then kind of be the straw that breaks the camel's back, for lack of a better term here, and trigger the onset of more severe eating challenges.
Thank you. Um, so someone mentioned that their son was recently diagnosed with non-alcoholic liver disease due to his ARFID. Um, is
Mm,
that fairly common?
that's a really great question. I don't know that I can speak to that specifically, not having a medical background, but it's something that I can kind of take back to our med team and see if someone else could answer that question.
Okay, thank you so much. So our next question is, can you talk about whether ARFID is more prevalent among kids or teens with medically necessary food restrictions?
So when an individual has to be on medically necessary food restrictions, it certainly poses a risk for ARFID. So it's not uncommon for us to see, like, when there is, let's say, a co-occurring GI condition where there are some medically necessary kind of dietary restrictions. For if that person develops a significant fear of kind of veering outside of those dietary restrictions, or maybe they take those medically recommended restrictions to an extreme where they're kind of going above and beyond even what their provider recommended, then that's where we would be thinking about ARFID. So I think it's something that we always want to keep an eye out for when anything is kind of medically recommended in terms of a dietary restriction. So we can see that clinically.
Our next questions are related to treatment modalities. So can you talk a little bit about treatment modalities to address ARFID that starts after gastric bypass surgery?
Let me just look at this question really quick here in the chat here. Okay, if this is an adult who's developed ARFID after, oh, this is a great question, very much related to the one previously. Um, the treatment modality that I would recommend for an adult would be CBT AR. So again, that's cognitive behavioral therapy for ARFID. Um, this is a really nice treatment modality for individuals who are fearful of GI symptoms related to either a surgery or some other medical condition, because there are specific interventions within CBTAR to address those fears. So within CBTAR, we use a lot of exposure work. So that means like really working with the patient to identify what are the situations you're scared of, and then how do we kind of thoughtfully and collaboratively expose you to some of those situations to help you learn that you're able to be in those situations without something terrible happening to you. So for GI discomfort, we can actually do something that we call interoceptive exposure. So having someone kind of sit with the experience of feeling that GI discomfort, feeling the feelings of fullness, maybe the bloating, have them engage in some coping tools to ensure that they're still able to eat what they need to eat, even in the face of GI discomfort. I will say, whenever there is a history of gastric bypass surgery or any other type of bariatric surgery, we'd want to work really closely to ensure that there's collaboration between our team and the patient's outside medical provider so that anything that we're doing is still in line with the medical recommendations that the patient has.
Thank you so much. And similarly, someone is asking what treatments you would suggest for a child who has a G tube because of their ARFID diagnosis.
So, depending on other aspects of the child's presentation, their symptoms, and their reasoning for a G tube, these patients can be effectively treated by either FBT for ARFID or CBTAR, and they could potentially be treated really effectively in a virtual setting as well, but it's just going to depend on the patient's presentation. But oftentimes in these cases, there is motivation on the part of the family and the patient to wean off of the tube. So, for a period, it might be kind of coordinating with the outside provider to ensure that the patient is getting enough via the tube, but then kind of coming up with a plan to slowly increase oral intake and then decrease the tube feeds. The specific treatment, though, would again depend on why the patient has a G tube and what the challenges are. So, if the challenges are related to um, like feelings of fullness and not being able to eat enough by mouth in order to kind of get enough to eat, then we might be kind of in that space of like looking at those interoceptive exposures again. So oftentimes weaning off the tube becomes a part of the treatment process, and we would do that in close collaboration with the outside medical provider.
Thank you. Some more questions are coming in. What do you see in terms of ARFID and mast cell diseases?
Um, so I think that there can be overlap. So with mast cell diseases, there can be very necessary dietary restrictions in order to not trigger an episode or reaction. So in those cases, we would want to do a very thorough evaluation of and understanding of what exactly are those food restrictions. And again, if the person is kind of going above and beyond what the medical provider has cleared for them to eat, so the person is now restricting even within the range of foods that they're allowed to eat, then we might be thinking a little bit about ARFID. Or if the person is exhibiting a lot of fear that's like disproportionate to their condition, then we might be thinking about ARFID. I think about this very similarly to individuals who experience food allergies. So, anytime we're working with an ARFID patient who also is experiencing food allergies, we always want to have a really clear understanding of what is actually safe for the person to consume, what is not safe for the person to consume, so that our work can really focus on expansion of dietary variety that is medically safe for the person to be eating.
Yeah. In terms of programs, is there a specific program for athletes with ARFID?
So I will say that we don't necessarily have like a program for athletes, but we do have quite a bit of programming within Equip for athletes. So by that I mean we have some athlete specific groups, as well as workshops that are geared for not only athletes but caregivers of athletes. And then we also have some folks on our dietary team, like our RD team, who are specifically trained and working with individuals who are athletes so that they're able to support those unique needs.
Thank you. So someone's experiencing some difficulties in terms of their teen. So they've been trying for some time to support their teen with celiac, who eats very limited. So they're wondering if you have any suggestions for support for parents when older teens are refusing help.
That is really tough. I know teenagers are just really tricky. And even if you were able to get your teen into treatment, sometimes it's really hard to get the teen to engage. Um, I would say sometimes it's about kind of guiding the teen. Well, I've got like two answers here that are kind of bopping around in my brain right now. So, the first is like working with the teen to kind of identify how are the eating challenges getting in the way of the teen's life. So, kind of building motivation by having the teen really identify if the food restrictions are getting in the way rather than the parents saying like, okay, I see it's getting in the way in X, Y, and Z ways. Like really work with your teen to identify and then have the teen also identify what potential treatment goals could be. And that could be a way to motivate seeking some support or treatment for the food challenges. The other thing that I've seen parents do is, and this is, I think, really up to each individual family, but it could be leveraging certain motivators to get their teen to go to treatment. So maybe it's kind of identifying like if you want to be able to do this thing that you really want to be able to do, then I need to see you attending treatment for X number of months. So that is also an angle that some parents take, but it totally depends on the family dynamic. It totally depends on the teen themselves too. But I have seen that sort of like leveraging of contingencies work in some cases. But of course, whenever possible, we of course want the teen to at least have some level of buy-in to treatment. And so I think sometimes going that more kind of like collaborative, like goal identifying, goal setting route can be a really nice place to start before you go down the route of like identifying contingencies to use.
Thank you, Tana. Another question that came in is, can picky eating turn into other types of eating disorders besides ARFID?
So a really good question. I think there's some early research on like the crossover from ARFID to something like anorexia, let's say. Again, this is like very early work. I could see anecdotally sometimes this can happen. So an individual who's already struggling with their variety of intake, like they're struggling with their selective eating, and then they develop really significant body image or weight related concerns, and then it kind of turns into something else. So it's certainly something that can happen. Sometimes what we see is sometimes what we see is patients who admit to us with a diagnosis of anorexia nervosa, and there's a history of ARFID. So over the course of working with the patient, we kind of learn like, oh, there's also selective eating, but right now the main thing that's getting in the way is the fear of weight gain. So it can happen. I don't know about exactly what the mechanism is that can kind of lead to that crossover, but my hunch is that for individuals with ARFID, there's again like already that vulnerability to challenges with eating, and then you layer on like that body image distress, peer pressure, societal pressure on top of that and come sometimes then like spurring the onset of a different disorder like anorexia.
Uh, We have one other question that came in. Sorry, it's a little bit of a long one. So, this individual is having a little trouble with FBT. When it comes to parenting styles, there's a lot of family trauma, and there
Mhm.
are some providers who are unfortunately not really knowledgeable on ARFID and eating disorders. Would online support work? Um,
Let me see here. Online support can work. When it comes to FBT for ARFID, and FBT in general, I think this is a really good question about, well, how can FBT work if there are different parenting styles, if there are maybe two different households. A lot of FBT is about empowering parents or caregivers to be on the same page for their child, even if there are different parenting styles, even if there are different households. So, but if there have been challenges with FBT for ARVID, the beauty of equip treatment is that we can also try a different modality. So if FBT is really not jiving, it's time to try a different treatment modality. We could try something like CBT-AR in these cases. But a lot of FBT and even within CBT-AR is, trying to help parents find some alignment so that we at least have some shared treatment goals, shared approaches, regardless of what household the patient might be in.
are you able to talk a little bit more about the intersection of ARFID and people on the spectrum?
Sure. And I apologize, my voice is like quickly leaving, but I have a cough drop now. Um, so there is a significant degree of overlap between autism and ARFID. I think research suggests that that overlap is anywhere between like 12% and like even 30% in some cases. So we do see that overlap. In terms of symptom presentation, we see that selective eating, so having those challenges with dietary variety, sometimes having specific food rules or rigidity, those are present across both. And so we can provide treatment for ARFID even when there is co-occurring autism. And I think in those cases, it's really meeting with the family, meeting with the patient, understanding. how their autism shows up specifically. If there are strategies that have worked for them with managing other symptoms related to their autism, we would try to work those into treatment as much as we can. If there's an outside provider kind of helping the patient with their autism, or maybe it's another aspect of neurodiversity, we would also connect with the outside provider to learn, okay, what is the treatment that you're doing, or how are you supporting this individual? And how can we ensure that our treatment for ARFID is compatible with the work that is being done outside of EQUIP? So in many cases, these like behavioral approaches that we use in CBTR can be a really nice fit for people on the spectrum, but it totally depends on the specific person and tailoring the treatment plan so that it's responsive to the unique needs of the person. Because one person with autism is not the same as another person with autism. So we also want to be mindful that we're kind of individualizing the treatment to each person.
Okay, thank you so much. Someone's asking if you have any recommendations for providers for any specific trainings.
Um, we have at Equip, we do something called an Equip Academy. I believe it's monthly. And we've got a couple specifically on ARFID. I cannot remember honestly if those are recorded or not. Um, but that could be a potential resource. You can earn CEs by attending those Equip Academy trainings. But I'd have to get you a little bit more information on exactly when they're offered and when the next one might be on ARFID.
Okay, thank you so much. Um, Relatedly to the question that we spoke about a few minutes ago on ARFID and FBT, there was a question of medication, especially with co-occurrence of like anxiety. So can you talk a little bit about that?
I can speak a little bit about medications just from my vantage point as a psychologist, but because I'm not a psychiatrist or have that training, I wouldn't be able to speak very much in depth. But my understanding is that there are currently no FDA approved medications for the treatment of ARFID specifically. However, there are some medications that psychiatrists might use in order to help with symptoms. So some of those medications might be specifically geared towards targeting anxiety, as mentioned. But there are also some medications that have become interesting to psychiatric providers because of characteristics related to like increasing appetite. So for some patients who struggle with their appetite, there's been some interest in exploring the use of medications to help with that. So again, nothing that's FDA approved, but there is some. Um, I know that there are some practicing psychiatric providers who do utilize medications in their practice, and I personally have also worked with patients who have really benefited from certain psychotropic medications.
Okay, thanks so much, Tana. We do still have a few minutes, so if you have any questions, please feel free to utilize the chat Q&A feature. We're still here for a few minutes, so we're happy to answer any other questions you'll have. I'll give everyone just another moment or so just to think of anything we might have missed, any questions you all have.
I see there might be a follow-up question about the
The
teen who
celiac.
celiac. Yep. So we'll
Mhm.
wait for that one to come in.
Some people are just asking about equip in terms of insurance. Is it accepted like private insurance or is it just private pay?
We take insurance. Yes. I do not have the full list of insurance or health plans that we take off the top of my head, but that's definitely something that you could talk through with our admissions team.
Before we get to the celiac teen, we did get another follow-up. So, what would be the most appropriate way to support an adult who developed ARFID after gastric surgery is experiencing fear of digesting food, anemia, a result of limited intake, and is also being bullied about their eating difficulties?
So I think we answered this one a little bit earlier, but cognitive behavioral therapy or CBTR could be a fit for this individual. So if their fear of digesting food is kind of above and beyond what we might expect would be typical for an individual after a gastric bypass surgery, if they are eating such a narrow variety of foods that has not been cleared by their medical provider, then they, could meet diagnostic criteria for ARFID. And so in those cases, something like CBTAR could be a helpful modality for this patient.
Okay. While we wait for some of the final questions, I am just dropping our brief survey. We'd love to hear any feedback you have for us in terms of how this webinar went, any questions, comments. Um, we'll give it a few moments because I know someone had a follow-up.
Mm. Oh, that is so tough. And that situation is not uncommon. Unfortunately, that sometimes a parent will be kind of raising the red flag or, kind of really flagging something for a medical provider, but then they're kind of told like, oh, it's just a phase and they'll kind of grow out of it. But you as the caregiver kind of know that something is not right and you're worried about health. So, in these situations, again, like I've worked with caregivers who have utilized contingencies with their child. So again, identifying what would be the things that would be motivating to your teen and kind of requiring engagement in treatment if they want to be able to continue accessing that thing that is really motivating. Our teams at Equip are well versed in working with resistant teens, whether it's within FBT or CBTAR. So there might be cases where we would still be able to work with caregivers. We'll say it does become a little bit tricky with the teen where we would ideally want some level of participation from the teen, but we could work on strategies to get that involvement.
Thank you. Another question came in. Are there any books about ARFID that you recommend?
Yeah, so it depends on whether we're talking about caregiver books or patient-facing books. Um, there's a really great book. Oh my gosh, I'm not going to remember the name of it off the top of my head, but there is, I think it's called something like ARFID workbook for caregivers. Shivani, is there a way to send out like a resource list after this to
Yeah,
attendees?
absolutely.
Okay.
Mhm.
I've got a list. I just can't remember them off the top of my head, but I can get those over to Shivani to send out to the group afterwards, and I can include some both caregiver facing books as well as patient facing books.
Thank you so much. I'm going to do a final call for questions. Tana, you've been amazing today, so I appreciate your patience. I know you're not feeling so well, so thank you so much for being here with us.
I actually feel fine. It's just my voice sounds a lot worse than I feel.
People are just very grateful that you're presenting all this amazing information and answering their questions. I'm sure it's a lot for everyone, so I appreciate you all being here. Um, Mm, just dropping a couple of links in there if you want to learn more about Equip. Yes, we will. This is recorded, so you'll receive a copy of the recording in the next few days. So no worries about that. And then we'll also include the resource list for folks, so you have access to all of that moving forward. I'll give it one more minute. Okay, I think we're just about wrapped up for today. Everyone, thank you so much for joining us. Tana, again, thank you for sharing all your knowledge and being here for our community. If you would like to learn more about Equip, I did drop the links in the chat, and I also included Meta's screening tool, available both in English and Spanish. And if you're looking for more information about ARFID and that screening tool that Equip has, the link is there as well. We'll also include it in our follow-up email. Um, when the webinar ends, there will be a feedback form. We'd really appreciate any thoughts you have on this webinar. We really appreciate the input so we can help support our programming moving forward. Other than that, thank you all so much for joining us tonight, and I hope you have a good rest of your evening. Take care.